This is Dr. Jennifer Jansen from the Zepf Center. You're listening to JJ's Clinical Connection, connecting you to clinical topics. Join me as we take a deep dive into the world of behavioral health and learn about hot topics, innovative approaches, and top-notch professionals shaping our industry. As the weather starts to cool and the leaves change color, autumn is one of my favorite times of year. Halloween festivities also begin around this time, and although it can be fun to visit haunted attractions and get your costume ready, this season can perpetuate some harmful stereotypes about those living with mental health conditions and substance use disorders. To help us debunk some of these myths and misconceptions, we're joined this month by our Crisis Prevention Intervention team. These clinicians help train Zepf Center staff to support clients in crisis and to de-escalate situations in a non-violent, non-physical way. In this episode, you'll learn more about crisis prevention intervention techniques, how they are utilized here at Zepf Center, and how they positively impact clients and staff. We'll also explore the truths behind myths and discuss how stigma can stand in the way of healing. There's a lot to unpack in this episode, but you're in excellent hands with this team of dedicated clinicians. Stay tuned. Today I'm joined by a very special group of Zepf Center clinicians, our Crisis Prevention Intervention team, or CPI trainers. Together we're going to bust some myths about mental health conditions and substance use disorders. But first, let's learn a little more about CPI and how it supports staff and clients here at Zepf. Well, good morning. Would you like to introduce yourselves to our listeners?
Good morning. Yes, my name is Madeline Bercio. I am a coordinator for our case management team here at Zepf Center and one of our CPI instructors. So I have been instructing CPI for just over a year now. I think I'm one of the newest.
Hi, my name is Andrea Murdoch. I'm the Director of Youth Services. I also am one of the new ones and have been instructing for a little over a year. It's been great to be added to the team.
My name is Kara Oligschlager. I am the manager of community services in our case management department, and I've been teaching CPI off and on for 25 years.
Good morning. I'm Bruce Stevens. I am a crisis coordinator with our crisis department, and I've been a CPI instructor for 4 years.
Great. Well, can you tell our listeners exactly what crisis prevention intervention, also known as CPI, is and how we use it here at Zepf Center?
CPI also means nonviolent crisis intervention. CPI is the name of the company that developed it. They came around in about 1980 when there was a lot of things happening in the mental health field. They operate under the philosophy of the care, welfare, safety, and security for everyone involved, whether it's the staff, the people that we serve, the community, visitors, anybody who is in our area helping to provide support. It also reinforces the concept that all behavior is a form of communication.
So with CPI, I think specific here to how we utilize it at Zepf Center, we serve such a wide array of individuals, so many different populations in so many different settings. And so as an agency, we do need to have some method of how we are going to respond to crisis situations, how we're going to support our clients, how we're going to support our staff. And the CPI model is the model that we use here at Zepf Center. I think a lot of people go into it when they first learn it, when they're first trained on it, as great, this is how I'm going to respond to every physical aggression situation. And that isn't the case. CPI is really ingrained into every piece of our day. This is about recognizing behaviors. This is about being supportive to our clients. This is about understanding where they come from and where they're going, in addition to how can we safely de-escalate and respond to more escalated situations.
I would also say it's a great tool for our agency to have. No matter what department that you work in, you're able to get the same level of skills needed to interact with clients or coworkers and help with de-escalation, whether it's in our financial department or you're a clinician on the CSU. We're all taught the same type of skills to help with these types of behaviors.
Andrea, that's a great point because I know that not everybody that comes to Zepf Center for employment has a background in mental health treatment. And so we have to start somewhere with our training and our onboarding. And my understanding is that CPI is part of that onboarding experience.
Yeah, absolutely. Everybody that is onboarded at Zepf gets CPI training as part of our new hire orientation.
And part of it is CPI is proactive. It's not reactive. And what I mean by that is when we first have employees, we think it's important for them to go through the orientation process and understand and learn the CPI principles, is that when we say behavior is communication, all behavior is. So it's not just the words that people say, it's their facial expressions, it's their body language, it's the tone of their voice. And what CPI really encompasses is being able to recognize those things before that tension might rise or that anxiety builds up. And it's really being proactive and having the appropriate approach to help the client and de-escalate situations.
I love that, Bruce, because I know that the P in CPI is really about prevention. And so if we can intervene early, we can prevent things from getting more intense. How do the CPI techniques help manage behaviors and help support our clients?
Well, as Bruce said, it's very much about prevention, recognizing behaviors and emotions as they're coming on. One of the myths of emotions is that they can be good or bad. And CPI reminds us that they aren't good or bad, they simply are. That emotions are normal based upon things that happen in our life recently, long periods of time ago, that by recognizing the behaviors and the emotions that are being expressed and not avoiding them, engaging people as, again, they begin to feel that tension and or they're struggling or the emotion becomes too much.
You mentioned that all behavior is a form of communication. How do you identify and respond to these behaviors as the clients exhibit them?
Validation. A big piece of not assigning a judgment to emotion is recognizing that it is. And validating, even if it doesn't make sense, that emotion is. And it's a universal experience for humanity that we have those emotions. And so it can come out in forms of behavior, which is unique to the individual, which also suggests that relationships are in the therapeutic setting are really, really important.
Absolutely. And I think that with all behavior as a form of communication, I think when people get ready to come through training, they're ready to focus on these negative behaviors. And like Kara said, behaviors just are behaviors. Emotions are emotions, but they're communicating something. And even these, pleasant, positive behaviors are communicating something. They're communicating trust and safety. And so if we're seeing the opposite of that, is it communicating that we're maybe not feeling very safe right now, that we're feeling like we need to be on guard, that we need to protect ourselves? So I think as far as being aware of these behaviors and trying to identify them, our role here at Zepf as staff, as anybody who comes in contact with a client, is to remember our professional role, remember that we are here to foster that environment for the client. And I think that's a big part of where rational detachment comes in. When we're teaching CPI, one of the pieces that we focus on is we are also humans and we also are going to have emotions, right? And so I think when we have to be ready to identify behaviors and identify them in a sense of, I want to prepare to support you, we have to make sure that we are staying rationally detached, that we are not stepping into an area where we're taking these behaviors personally, that this isn't about us. This is about how they feel in the moment and what they are trying to communicate.
I love that term, rational detachment. Can you say more about why it's important for our staff not to take other people's behaviors personally?
Well, I think a big part of that is a lot of our clients have experienced trauma and have had a lot of bad experiences, and they might not have the words to express those intense feelings and emotions that they're experiencing. So their behaviors might express those intense feelings and emotions. And we need that rational detachment because we don't want to judge anyone or judge their actions or their behaviors. They're trying to express something to us. And that rational detachment allows us not to be judgmental, but to be trauma informed and respond in a warm and supportive way to help them get through that traumatic process.
Yes, Zepf Center is a certified trauma-informed organization through the sanctuary model. How do these sanctuary tools complement CPI techniques?
Almost perfectly, honestly. I think that as we go throughout training, and especially we are now on an edition of CPI that is specifically trauma informed, that is now in the title of the versions that we are teaching. And it's really wild how much that they line up. I'm able to work in almost every sanctuary tool that we have into CPI training. So that could go from anything like debriefing after a crisis and using our raised flag tool. And both of those really emphasize doing this in a trauma-informed fashion and a future-oriented fashion of how does this move us forward? How can we continue to work better as a collective treatment team, both staff and client, to even just when it's appropriate to self a situation when a client maybe isn't feeling safe, using our safety plan to stay rationally detached in the moment when we're becoming overwhelmed. Honestly, fits in so well.
It's also really nice that when we are training people for the first time for this, they're getting it right after sanctuary training. So they've gone through a couple of days where they have these tools in their brain, they know what they are, and we're able to connect the dots the next day with these are how you use them in practice, these are how we use them as an agency.
We know that research shows that burnout in this field and helping professions is quite high. What would you say is your goal for using these CPI techniques?
Improved communication, excellent communication. It's the ability to treat the folks that we serve as individuals. It can become easy in many ways to sort of group and lump people together. These people behave this way, these people behave this way. By treating people as individuals and not problems, but that they have emotions and the sum of their parts that bring them to us, that it makes it easier and more logical to not take it personally, because this person, the folks that we work with, and we do our best to help them in every way that we can, they've come to us for help because their situations and or their lives have become unsustainable or untenable as they are. And we're not gonna fix everyone. We're not gonna be able to meet everything that they need all at once, but it's a process. And in that process, it's the journey, not the destination, that we learn about who we are in that journey. And so by going along in that journey, because we have the privilege of just going along it with that individual, it's not personal. They're working on their stuff. We try to help develop tools to get to cope with the things that they're dealing with, and recognizing that that privilege is pretty powerful stuff really does help us separate and not take things personally.
Well, and I think CPI does a great job too in the moments where, I mean, you're right. I think it prepares us a lot to not take it personally and to be aware of all the factors that come in both in our life and our client's life, so that we can try to stay detached. In the moments where that doesn't work, in the moments where we maybe are getting a little burnout, taking things personally, becoming a little overwhelmed with the situation, I think CPI does a great job of emphasizing how important it is to ask for help. To use your coworkers, to use the rest of your team. This is never something that we should have to manage on our own, and something that we shouldn't manage solo if we're not in the place to continue doing that. Bring somebody else in. Everyone should be responding and checking on a situation. Who else needs tapped in that moment? Who can help go somewhere else with you while you try to use your safety plan and maybe try to recenter yourself a little? I hope that everybody leaves CPI understanding that you do not have to be the savior in any situation.
You know, Zepf Center serves upwards of 10,000 youth and adults in our community, and they come to us looking for guidance, looking for help. Can we talk a little bit about some of the client experiences that they come to us with? What are some of the barriers that our clients face even before they reach our doors?
Well, you mentioned trauma, and we use tools to identify trauma, such as the ACEs, and homelessness, socioeconomic struggles, mental illness itself, such as psychosis. There's so many things.
And these are the precipitating factors that we learn about and teach about in CPI. It's all of these pieces, right? It's really long-term pieces, more chronic pieces like trauma, childhood trauma especially. And then it can even be these shorter term, just day-to-day precipitating factors. Did somebody yell at them this morning at the bus stop? Did they get in a fight with someone before they came in? Did they not have shelter last night and they haven't eaten in 24 hours? There are all these different pieces when somebody finally comes through our door and is face to face with us that we're unaware of truly until we start to talk to them and try to get a feel for, what has been happening and how we can best help them. So both these very long-term chronic items and even just day-to-day things that even impact us, right, are going to absolutely impact how they come in through our door.
And I think there's still a prevalent stigma about mental health. A lot of our clients are very hesitant to come in and ask for help because they don't want to be judged by society, and they ask the questions, are you going to think I'm crazy? Or they think that the symptoms that that they're faking it, that they're just, making these symptoms up and that they don't have to deal with it on an everyday basis. And overcoming that stigma is very difficult to even get them to come through the door to ask that help.
Absolutely. And no matter what season, the myths and the stigmas surrounding substance use disorders and mental health conditions are a big part of our culture, especially around Halloween. Why do you think these stigmas continue to be reinforced in today's society?
I really like when I first started learning how to train CPI. One of my first shadow sessions was with Kara. And Kara said something during that training that I think is really important to how we view this stuff during today, and which you started to allude to, that when CPI came around in the 1980s, that was really the last stage of truly ending deinstitutionalization to the point where they were actually shutting down, that there truly were less facilities, very, very few. And we were taking this community-based approach, that this is now how we are going to treat the individual in the community with their support system available, in their homes, the places that they feel most comfortable. I think that a lot of the stigma that we see today still comes from that time period. It comes from this time period of, if you do not fit into this norm, if you have symptoms that aren't what society wants to see, that we put you away. And I think that there was maybe a lot of concern and fear and worry during the time of deinstitutionalization of, well, these people are so sick that they had to be locked up and now they're going to be in my community. And unfortunately, I think that really continues to propel a lot of society's concerns.
Yeah, it's the fear of unknown, like not knowing how someone's going to be responding to a situation. If you cross someone in the street and you're seeing some behaviors that aren't normal to you, you're afraid for what you might witness or what this person might do. So being able to help normalize those behaviors and help give people the tools on how to react in those situations is really what CPI is about.
There's also a lot of discussion in social media about mental health these days. I think it's a lot more prevalent to hear people recognize and call out their own and own their mental health issues. It's still just the beginning of the conversation in that we've had a lot of celebrities of recent who said, I'm having some mental health stuff. I'm going to take a step back. I'm going to take care of myself. We still are generalized in those conversations. It's my mental health. Do we need to get specific? I don't know. It's what people are comfortable with. But as it becomes more normalized as part of our society, and again, existing on social media, how we talk about our mental health is really the powerful piece that we're seeing almost explode in conversation. You'll see people who are apologetic about their emotions. I'm sorry, I got upset. Or don't get angry, young lady. Or a lot of those old belief systems really are starting to fall by the wayside, which is very exciting for the people that I work with, because that's what we do. We're not so avoidant of emotion as we had been. It's still uncomfortable. And as Andrea said, the fear of the unknown, or just being able to say our own truths out loud, and that fear of judgment that exists in our own homes, and of course, again, across social media.
And I think part of that too is when clients are dealing with these intense emotions and their mental health symptoms, that's part of who they are all the time, all their life. But there's still that blame game. And just for me, I have diabetes, so I have to plan my meals. I have to plan my medications. I have to count carbs and do all those things. I have to do that all the time, every day. If someone has a mental health diagnosis, they have to do the same thing. And they have to understand what their symptoms are. And sometimes they express their symptoms in ways that make people uncomfortable. But it's not judging that and understanding that that is a mental illness and they are dealing with the symptomologies. Just like if I start sweating and having a low blood sugar, I need to eat something. And we don't judge a diabetic for eating carbohydrates when they're having a low blood sugar, but we still judge patients and clients that have mental health symptoms, and it's just a process of their disease.
Bruce had such a good point. I'm wondering what you guys think about how myths and stigmas continue to affect individuals who are living with mental health conditions or substance use disorders. How do you think these people are impacted by these myths?
I think one of the biggest things that I see day in and day out, and this might be specific to my role in this integrated care capacity, where we're really helping to coordinate and thrive in our community. I think one of the biggest impacts is being dismissed. I think there's a lot of dismissiveness around individuals who sure experience their own symptoms, but who also might have symptoms that are more visible to the public as well. The amount of times that we see a different outcome or have a different response once somebody from their treatment team steps in, because as they were trying to advocate for themselves alone without that, they were dismissed. I think that's truly one of the most impactful ones. If you can't even get somebody to take you seriously, to hear you out, and to truly care about you as a fellow human because you have symptoms impacting your day-to-day in some way, shape, or form, that's already a pretty big barrier to day-to-day life.
Yep. I talked about validation a little bit earlier, in validating the expressed emotion that an individual is having. Another tool that we use is empathy, and the importance of the concept of putting yourself in someone else's shoes. How would I feel if I were experiencing what they're experiencing? That's not to say that people can behave any old which way. Anger is anger, and it's a natural and normal emotion. Punching a hole in a wall, not so much. We can set some limits and boundaries on those things, but give people a safe space to express their emotion. We still have those stigmas in society that expressing emotion implies a weakness. And that's very hard for some people to do in a lot of settings, but we try to make it in a safe space where, in the work that we do, that people have the ability to express those emotions, even if they don't make sense. And that's where empathy is a key tool in our toolbox, to empathize with the myriad of emotions that people bring to the table or that are erupting in their in their lives. That's a key for us.
Carrie, you touched on one of the most common myths, which is that individuals living with mental illness can be violent or are violent. How does CPI and trauma-informed care techniques prove otherwise?
We spend a lot of time on this in CPI. I want to emphasize that we don't spend as much time on this as we do learning how to identify warning signs and how to be supportive in the moment so that we don't even get to an escalated point. But sometimes it does happen, right? And so in those moments, I think one of the most challenging pieces for individuals learning CPI is looking at their own lived experiences and how that is impacting their response to any given situation. CPI has a specific tool that we use called the decision-making matrix, and it lays out what is considered low risk versus high risk. And we do an exercise during training where we'll have a scenario, we'll look at it, and we'll ask everyone around the room, where do you think this falls on the decision-making matrix? And every single time, everyone has different answers. And it will be because somebody thinks, this is a less risky situation because I've worked inpatient all my life and that's nothing, versus that I can't believe that's the highest risk situation you could imagine. I could be hospitalized and incapacitated because maybe they had a really bad experience once where something similar did happen. It doesn't mean that every single situation is going to play out the same. And it is so important that we learn how to remain objective and unbiased in any escalated situation. And it's hard to do, right? Because again, we still are human and we have all these experiences and precipitating factors ourselves that impact how we respond. But that's part of the training. That's part of learning. How can I remove some of that? How can I remove some of the bias? How can I stay objective? How can I look at the facts in the moment to truly understand the risk level here?
Absolutely. It's the message, not the delivery. Hear what people are saying, not necessarily how they say it. We perceive that someone screaming at us is being violent, when in fact, again, they're just expressing an emotion. And some people, they have to let that steam off to be able to get to what's going on underneath it. And so that's one of the, along with the decision-making matrix, we create a situation or a space for people to express those emotions, let some of that pressure off, and then turn to the teachable moments. Where do we go from here? Just because it's loud doesn't mean it's dangerous.
Yeah, I think when we're training CPI, we talk a lot about safety. So we want to make sure that the clients are safe and the staff are safe and everybody in the room is safe. And if those things are all happening, normalizing that it is okay to let someone scream. It is okay to let someone have some type of outburst, because that is what they need in order to reset themselves before you can get into the work where you're identifying what's going on and how to move forward. As long as everybody is safe and no one is in danger, it's okay to let that stuff happen.
And I think it's important too, and what CPI teaches us is to remain objective and not judging someone just because of their diagnosis or their symptomology. You can be delusional or paranoid or even in psychosis, but you're still a human being and you're going to respond to empathy and kindness and not being judged. Our clients are very perceptive and they understand when they're being judged or when someone has preconceived notions or prejudice against even their symptomology or their diagnosis. And not having that and being open and empathetic towards them and understanding that is a big part of preventing escalation.
Bruce, I think that's a really great point. And I want to point out to our listeners that there really are two types of aggression, right? There's proactive aggression, which is rooted in a self-serving behavior that has a callous disregard for other people, right? And that's what we think of typically, people aggressing someone, coming at them with a weapon with the intent to do harm. But the other type of aggression is called reactive aggression. And this is rooted in the amygdala part of the brain, right? It is a fear response to either a real threat or a perceived threat. And reactive aggression responds well to both respect and empathy. That's something I've heard from each of you as you approach these situations with the CPI training and information. And I think it ties back to our sanctuary trauma-informed care model, really creating safe spaces for people so that they don't feel afraid.
As a reminder, one of the concepts with sanctuary is that uncomfortable does not mean unsafe. And that's where we're able to tap into the empathy and respect when we're working with someone who may be expressing some emotional dysregulation is that we can still respect the humanity as well as the struggle that they may be going through, whatever the precipitating factors may be. Again, people are the sum of their parts, and they don't come to us like a car. I hear a knocking in my car. Can we fix that knocking? They come in with all of the emotions and all of the stuff that precipitated that moment. And we have to triage in terms of what's going on with them. What is the emotion that they need to express, creating that safe place, but respecting their need and their right to have those emotions.
Well, and it ties right back into what we talked about at the beginning, right? That all behavior is a form of communication. And you're right, this reactive response, this reactive aggression is stemming from something, right? It's still communicating something. I think that's such a good point to make, that in most situations where we're facing a situation where somebody is escalated or aggressive, it's not coming from a place of, I want to harm you or take something from you or destroy something. It's coming from a place of, this is how I feel I need to respond in this moment where I feel threatened, where I feel unsafe, where I feel unheard. And it's why I know it sounds maybe cheesy for us sometimes to keep throwing around the CPI quotes and tools and models, but it's such a big one. If we can acknowledge that the behavior that we're seeing is coming from something and pull in these other sanctuary and CPI tools of, how do we debrief? How do we do a raised flag where we identify what was happening in that moment? Did we miss something? Did we miss a sign leading up to this? Do you need a different support in the moment than what we've offered you so far? And what can we try to do going forward? Because we certainly don't want this to be how you have to respond. We don't want anyone to have to feel escalated to get their point across. So what can we do so that that isn't the response going forward? But we have to start with acknowledging that that response came from it didn't come from nowhere. It came from something.
Sometimes people are allowed because they haven't felt heard.
Yeah.
Very much
Yeah,
so.
absolutely.
So let's talk a little bit about the new Joker movie that was just released in time for Halloween, and its depiction of an individual living with mental illness. I think this relates a lot to our topic and our conversation around stigma with mental illness and how we might take a trauma-informed approach. What are some of your thoughts about depictions of mental illness in the media?
Oh, wow. That's a huge question, because we talk about mental illness in the media. We don't always get to see it as it plays out on a large screen in front of us. And it can be scary and it can be uncomfortable. And the movie ends, the credits roll, and you can walk away from it. And good art makes us question ourselves and what our perception is. And it's powerful that we're starting to see these conversations happen in real life, as opposed to, this is what happened after the fact. It created and it draws the viewer into all the emotions that exist, and emotions that maybe seem conflicting. So it's really powerful that we're starting to see that in real time, and that we can step into it in sort of a safe atmosphere, because again, the credits do roll at the end. You finish your popcorn and you go home. So I applaud it, even if it does bring on some of those uncomfortable emotions.
I think, we're seeing a great trend here where we're normalizing it in the media and in entertainment. It's really helpful for adolescents to see this stuff on the screen or on TikTok, or see their favorite football player or gymnastics person, recognizing that they have mental health issues. The Barbie movie is a great one as well for youth to kind of see mental health pictured in a movie. So I think this trend is positive, and I hope it continues to be that way. I mean, you always see negative stuff, but I think right now there's a good trend going with making this more normalized for youth and teens and adolescents.
And there are parts of it that continue to be conflicting, I think, right? There's the idea of, if we look at the Joker, for instance, that, we get to maybe see something that we don't see in our day-to-day lives of what does this look like for every second of every day for an individual to be experiencing active symptoms, right? That's something that not everybody sees every day. And so getting that insight hopefully brings more awareness, hopefully makes people think, absolutely. On the other side of that, the Joker is still a villain that kills people, right? And so it's just so conflicting that I think getting, to see this perspective, maybe hopefully that does make people think, and hopefully we're able to, kind of have this realization of, man, this is day in and day out for individuals who have these chronic mental illnesses. But then at the end of the day, are we still perpetuating myths by watching the Joker continue to, live on as a villain and do villainy things? It's hard. I think it's still progress overall. I think, like you said, Barbie's a good example, right? We have the Inside Out movies. That's great. Like so many good examples of here's positive depictions. And I don't want to say that, that this is all negative specific to the Joker, but we're still kind of running into how does the typical individual look at mental illness at the end of the day?
And maybe that's a responsibility that we have to do as individuals and mental health professionals, but our audience and listeners have to do as well. They need to kind of take on these myths and these stigmas head on and understand that people that have mental illness are human beings and they deserve empathy and understanding and compassion just like anyone else. And, it's not going to change overnight, but we have seen progress, but it's up to us to continue that fight and continue empowering persons that are living with mental illness every day of their life.
What would you guys recommend to our community members for how they might help to fight against stigma around mental illness?
I think starting with what we've touched on already a little bit is normalizing, right? I at the end of the day, that's such a big piece. I think when we can normalize any sort of mental health experience that we go through personally, that our family members go through, if we can talk about it, feel comfortable talking about it, if we can receive it when other individuals are talking to us about it without judgment and receive that, openly and have an open conversation about it. I think that is a good start. There's always going to be someone out there who is experiencing mental illness for the first time or whose family member is experiencing mental health symptoms for the first time. And if you've never experienced it before, you might go into it with some of these preconceived notions and judgments about what that's going to look like and how you need to respond. I think it's a learning experience for everyone to start to be more open to the conversation and how that looks for each individual.
Ask for help. Ask for help as soon as you can. Don't feel bad about it. Don't be embarrassed about it. Ask for help. We have 24/7, 365 services that folks can reach out to. It doesn't mean that we're, sending a team out to your house at that moment. Ask for help early and be open to new ideas, suggestions, but people don't have to do this alone.
And I think there's a preventative part of that. We really emphasize preventative healthcare and doing those things ahead of time before the issue becomes a major problem. It's the same with mental health. And don't be afraid to ask for help before it's even needed, but as a preventative measure. Like we talked about, CPI is preventative and it's proactive. We want to do the same thing with our mental health, but some of that is having those difficult conversations with our kids, with our adolescents, with our teenagers, with, sometimes other groups that we don't feel comfortable with, and being comfortable with talking about it and doing those preventative things as well.
So being supportive is another way that we can help. You might not be the one that's experiencing a mental health crisis, but your neighbor or your friend or someone that you interact daily with, and they might just need to know that they have someone that they can talk to. We talked a lot about how, people might be afraid to recognize that they might have a mental health diagnosis or something along those lines, but being able to be supportive And even if it's like, I'm here for you if you want to talk about it, because you don't necessarily want to push that on someone, but they might just need someone to talk to because they haven't had that person. Everybody needs a village. So if you're the one to start that village, that's how you can be supportive in that role.
As we come to the end of this episode, you guys have talked about the misconceptions of care for our clients, especially for clients that are in crisis. And you mentioned that observation, empathy, and verbal engagement are way more effective than physical interventions. What final thoughts do you want to leave our listeners with in terms of how they approach others in their day-to-day lives?
The goal of CPI and conflict resolution isn't necessarily that we're fixing people or that the issue that created the strong emotions is fully resolved, but it's about moving forward. And so for a lot of respects, we equate crisis with violence. We don't equate crisis resolution, problem solving with crisis. And so it's evolving away from that. It's not a crisis unless something got broken. That the majority, by far and away, of the crisis resolution is done verbally. That a very, very tiny piece of it looks violent. It is also a learned thing, violence can be, and helping people relearn that they have options, that they have choices, that if their general history has been to become physical, we can help them learn they have options that isn't going to lead to either someone else becoming physically hurt, being involved with law and law enforcement, that they have choices and they have options, because a lot of people don't feel that they do.
For me, CPI is empowerment, and it empowers not only the individuals that have learned the CPI principles, but the people that we encounter. We're using our verbal interventions and de-escalation techniques to better understand and have greater empathy for that person, and it empowers them because they feel like they're being listened to, that they're being heard, and that's why it helps de-escalate. But it also empowers the individual that's utilizing those principles because they have tools that actually work. And we've all seen it firsthand in our own professional experience that these interventions and de-escalation techniques and having warmth and empathy towards people and giving them an opportunity to be heard do work.
As a community member, we talked a lot about fear of the unknown and what happens when you come across people. You might not be sure how to interact with them when they are in some type of crisis or some type of mental health situation. So as a community member, just reminding yourself about these precipitating factors that all behavior is communication. And, you don't have to get involved, but you also can be there for support if you know the person. You can interact in whatever way that makes you feel comfortable.
I think that my final thought with this is the same for maybe individuals in our community as it is for our staff here at Zepf Center when we're teaching CPI. I think one of the core messages that I really hope that everyone leaves with is the idea of crisis prevention and learning how to respond to a crisis is more about how you approach the individual and how you interact with them as they are going through these different levels and emotions, and less about what we do during the moment of escalation itself. I think that this belief that anybody who is maybe acting out, if you will, or who is escalated or maybe doing something that appears bizarre to you is always going to be a high risk situation or lead to something dangerous. I think that's the myth, right? And so if we can all be aware of the fact that the individuals that we're encountering are also humans, and as Bruce said earlier, that they are always going to respond to respect and empathy and support. That's what we need to go into situations with. That's how we need to approach situations, and that's what keeps situations from becoming escalated. That is the end goal of what we are trying to do.
I want to thank each of you, not only for joining me today for this conversation, but also for your work in shifting the culture around crisis prevention and intervention, for debunking the myths surrounding mental illness, and for helping others learn ways to create safe spaces for those in crisis.
Thank you.
Appreciate it.
Thanks for having us.
That brings us to the end of today's episode. I hope this conversation helped clear up some of the common myths regarding mental illness, and maybe even shifted how you think about those living in recovery. Remember, breaking down stigma starts with better understanding, and the more we talk openly about these issues, the more we can support those who are struggling. If you or someone you know is dealing with a substance use or mental health challenge, know that help is available, and seeking it is a sign of strength. If you enjoyed this conversation, be sure to download and share the episode. For the latest clinical connections, subscribe on Spotify, Apple Podcasts, or wherever your favorite podcasts are found. For more information about Zepf Center's trauma-informed care and other resources mentioned in this episode, be sure to check out our show notes. For more information on Zepf Center, visit us at zeffcenter.org or find us on Facebook, Instagram, and LinkedIn. This is Dr. Jennifer Jansen, signing off until next time.